Hello and welcome. My name is Holly Tumosa. I am a wound care certified registered nurse, and I've worked in home care for 11 years. Today, I'd like to share the findings from my RNBS 486 capstone project, an individualized diabetes self-management intervention. Type 2 diabetes is an illness that requires long-term care strategies beyond medical and pharmacological interventions to maintain good health and glycemic control. The American Diabetes Association classifies diabetes as a chronic disease and suggests that healthcare providers align their approaches to diabetes management with the chronic care model. This model encourages interactions between a collaborative care team and an informed patient. However, this model can vary from one organization or practitioner to another. The purpose of this project is to focus on one of the 6 core elements of the chronic care model, self-management support. Since the effectiveness of diabetes management ultimately depends on a patient's adherence with recommended treatment, the purpose of this analysis is to attempt to identify the best practice regarding teaching to help provide patients with self-management support. I conducted a single-subject intervention study with a 67-year-old Vietnam veteran, which consisted of 5 in-home visits. The patient has a history of diabetes, neuropathy, Charcot, lower extremity amputations, hypertension, substance abuse, post-traumatic stress disorder, and major depressive disorder. The patient is a Marine who served 1 year active duty as a scout. As a result, he was consistently exposed to Agent Orange. Despite being diagnosed with diabetes over 20 years ago, as of late, he has been experiencing increased complications. Because of physical and psychological limitations, the patient was unable to attend a group diabetes self-management program like the model created by Stanford University. With the assistance of my mentor, a diabetes educator, I prepared for the intervention following the American Association of Diabetes Educators protocol. Why did I pick this topic? In my practice, I've noticed an increased incidence of diabetes-related wounds, especially in the aging veteran population. However, the true impetus for this intervention was actually the patient I had the privilege to work with. A recent episode of Charcot in his left foot led to osteomyelitis, which ultimately resulted in a below-knee amputation. His preoperative hemoglobin A1C was 12. After the amputation, I provided daily wound care for the residual limb in the patient's home, and he shared a story that I could not help but react to. I will now share this story, but I want to preface it by explaining that the patient has no family or support system. I have cared for him off and on for the past 5 years for diabetic foot ulcers and amputations of 3 toes. Because of this, we've built a level of trust. After enduring a guillotine amputation to remove the infected bone and a definitive below-the-knee amputation for prosthetic purposes, the vascular surgeon who performed the second surgery issued a stern warning. I give you 5 years before I take off your other leg. You better do something with the pad on the bottom of your foot and take care of your blood sugar or else you'll be back. Exhausted and frightened, he admitted to having binged on ice cream, cookies, and chocolate over the past 3 months. I thought it would kill me. I never realized that I could wind up like this. As soon as the words left his mouth, I decided to change my focus of my capstone project from corporate sustainability to individualized diabetes education. I wanted him to know and understand how to use his empowerment for good. If eating sugar could wreak such havoc, imagine the power of healthy eating. The American Association of Diabetes Educators has defined 7 different focus areas to help patients to effectively self-manage their disease: healthy eating, being active, monitoring their blood sugar, taking medication, problem solving, healthy coping, and reducing risks. Since the intervention was individualized and based on collaborative goals and action planning, I familiarized myself with the focus areas but waited for guidance from the patient before researching for more specific information. Because the patient suffers from hypertension, I did share the new American Diabetes Association 2018 guidelines that all hypertensive patients with diabetes monitor their blood pressure at home to help identify potential discrepancies between the office versus the home blood pressure and to improve medication taking behavior. I advised him to take his blood pressure twice daily. The first measurement should be in the morning before eating or taking any medications, and the second in the evening. I also advised him to avoid taking his blood pressure immediately upon waking and to take at least 2 readings each time to confirm accuracy. In the first visit, I conducted a head-to-toe assessment, a diabetes foot screening, completed an intake form, and asked the patient to help identify his first goal. What health change would you like to make most? His response was, I want to learn how to stop my diabetes from progressing. I asked if he realized how healthy food choices and activity can contribute to his goal. His immediate response was yes. What is making it hard for you to meet your goals? I asked. His response was my depression. The patient then stated that he wanted to feel better so that he can become more active and care enough to take his blood sugar and insulin regularly, not just 4 times today, and then do nothing for 4 days. When asked if he believed depression was to be the main reason that he was not adhering to his treatment, his response was yes. Asked what the consequences would be if he was not able to relieve his depressive symptoms, his response was, lay in this bed miserable until I die. I asked the patient if he had any intentions on hurting himself, and he told me no. I then created our first action plan. Please try to monitor your blood sugars at least once a day and try to remember to take your medicine. In August 2016, after compiling, linking, and examining data of 55 million servicemen and women, the VA released suicide statistics by state. This data includes the most up-to-date information and provides the number of suicides for the year 2014. The suicide rate among middle-aged and older veterans remains high. Approximately 65% of all veterans who died by suicide were aged 50 or older. In 2014, 37 New Hampshire veterans committed suicide. 21 were aged 55 or older. In New Jersey, where I reside, 93 veterans committed suicide. 54 were older than 55. In Vermont, 24 veterans, 18 older than 50. In Massachusetts, 73 veterans and 39 were older than 50. I don't have time to share each state's totals, but unfortunately, none of the suicide rates are different than the national average. For the second visit, I had originally planned on administering a depression screening questionnaire, providing dietary and physical activity training, including meal prep, and lastly, answering questions and concerns. However, I had to change my approach because of the findings from the prior visit and because the patient scored a 24 on the patient health questionnaire. Research has found that the frequency of self-administered blood sugar testing has proven to be an important indicator of adherence to treatment. However, I was faced with more immediate physical and psychological concerns before the patient could be capable and willing to make his blood sugars regularly. During the visit, I referred the patient to his primary care provider, psychiatrist, and ophthalmologist. At the second visit, I also introduced the patient to new technology and apps. Utilizing the patient's tablet, we downloaded the Google Assistant app, registered on the VA's My Healthy Vet internet-based service portal, and installed an Amazon Echo that the patient had purchased prior and did not know how to install or use. I provided a quick overview of how to access each app and created a second action plan. Please continue to take your blood sugars and medication. Call the VA to make your appointments and try to use Alexa. Call me if you need any help. Shortly after leaving the patient's home, I received a call. You broke it. Watch this. Alexis, tell me a joke. No response. Alexis, tell me a funny joke. The blue light is coming on, but she isn't answering me. You broke it. I answered, try again with Alexa. That is her name. Since I installed the technology on the second visit, the patient had time to work with the apps. I have to thank Amazon because Alexa has made him smile more than I've seen in a while. The Amazon Echo has a robust reminder functionality, so we were able to set reminders for the ophthalmologist, primary care appointments, and call for transportation the day prior. We set reminders for reminders so that he could get oriented and get comfortable with the process. If he did not provide all the necessary information for the reminder, Alexa would prompt him. When I asked if he would use the Pill Time app, his response was, "No, I can't. I have too much to learn already." During the third and fourth visits, we also examined 3 VA-approved therapies, along with 1 experimental option for treatment-resistant depression. I obtained this information from the VA Department of Defense Depressive Disorder Clinical Practice Guideline. I also made telephone calls to the local VA to locate service care providers. I provided abridged verbal explanations for each of the therapies, and because the patient is visually impaired, I copied or downloaded articles and converted them to a larger font so that he could read them. Nitro PDF has an option to convert any PDF to a Word or Excel format, which was very helpful. During the 5th and final visit, we had more practice with the apps. We set more appointment reminders with Alexa. We also contacted the Veterans Choice Program. The Choice Program, coupled with the My Healthy Vet app, was the closest I came to collaborating with the patient's physicians at the VA. Because of wait time or unavailable services, the patient was able to go out of network for treatment for his cataract, retinopathy, wet macular degeneration. He was also able to meet with a limb salvage specialist. Results of the overall intervention. The blood sugar average pre-intervention was 206. During the intervention, 176.8. He also had increased adherence to taking his PO meds. I was unable to determine the insulin since his inconsistency. However, recognizing that the patient was forgetting to take his medicines, I had already begun tracking missed dosages before the intervention for the PO meds. I simply observed how many AM/PM compartments remained full in his weekly med tray when I poured his medication. In the 2 weeks prior to the intervention, he had missed 7 or 8 dosages. During the 3 weeks of the intervention, he missed 3 dosages each week. Last week, although it is outside of the study time frame, I want to celebrate because we had a week with 0 missed dosages of his PO meds. In order to help the patient adhere to his treatment program, I found that I was unable to solely provide self-management training. During the 5 visits, I had to enlist 4 other elements of the chronic care model. Regarding best practice, I can only recommend patience, trust, empathy, and negotiations. Encourage empowerment and use non-judgmental language. Seek referrals for your patient. Only 5 to 7% of individuals eligible for diabetes self-management education training through Medicare or private insurance plan actually receive it. And better outcomes were reported for interventions that were over 10 hours in total duration. Usually only 1 hour of diabetes self-management training can be billed as one-on-one, unless there's greater than a 2-month wait for a group. There's a barrier to group learning or insulin training is necessary. The Medicare will also pay for 3 hours with a dietitian for medical nutrition therapy as well. I'm happy to report that the patient and his psychiatrist have decided to try the ketamine treatment, and although he was nervous, he is looking forward to feeling well enough to take care of himself.